Good morning, everyone. Welcome to day 2 of the Science of Patient Engagement Symposium. We will get started, so please go ahead and take your seats, and we'll start in about 1 minute.
Good morning, everybody, and welcome back. I'm Susan Gaffney, and I'm the Executive Vice President here at the National Health Council, and we're delighted to have you all today. Want to make sure that I call everyone's attention to the fact that it is Mother's Day this weekend. So if you are a mother, if you have a mother, which I'm pretty sure all of you do, remember her this weekend. She's doing a lot for you, and probably, if not currently, had a lot to do with your healthcare journey. So yesterday, we heard from wonderful speakers, I think we can all agree, that address topics such as trauma-informed healthcare, how to engage with pediatric, adolescent, and young adult patient populations. We spoke about changes we can make to care better for those who've experienced gender violence. That was such a powerful session. There were sessions that focused on the challenges faced by those patients in the adolescent and young adult community as they grapple with research, insurance, and taking control of their health journey. A big transition. I know as a mom, that's something I'm looking at and learning a lot from what happened on this stage here yesterday. We heard from caregivers and children's book authors on how to talk to children and families with new diagnoses. And a theme I heard throughout the day was about being seen, treated in the healthcare system as a whole person, not just as a diagnosis or a disease. And honestly, that's what I love about my work at the NHC. I get to show up and use my skills and experiences as a professional in service of making the healthcare system better for everyone. But more than that, I get to show up as a mom of a child with a chronic condition, as a daughter-in-law to a political refugee who needs his healthcare to reflect his culture and his language and his experience, as a woman who needs research to reflect the truth of women's biology as distinct from that of men, and as a caregiver to parents who are left unable to navigate the system because of limitations put on them by their healthcare and a system that didn't always respect what they needed in order to get the care they deserved. And so as a professional and as a whole person, I'm excited to be here on day 2 and continue this excellent program and learn more from our powerful speakers. Today, we'll be continuing through the lifespan to discuss the patient needs and care for the adult population, with a focus on women's research and the aging community. And now, I'd like to welcome Dr. Devin Jop, President and CEO of the Association for Professionals in Infection Control and Epidemiology, which you might know as APIC, unless you want to say the whole name every time, and a member of the NHC Board of Directors. And he's going to walk us through some housekeeping and introduce our keynote for this morning.
Since we're talking about the lifespan, I'm about to turn 50, so I'm using readers today, so there you go. First off, thank you so much for the wonderful introduction. I'm so excited to be here, to be a part of the 2024 Science of Patient Engagement Symposium. This is an important symposium, and one that we really looked at yesterday and learned a lot about the lived experience from all of our speakers. This topic is to me very exciting and relevant to all of us working in healthcare, research, delivery, and advocacy. The symposium is quite unique in ways because when we think about healthcare, we think about it in monolithic terms. But in reality, the lifespan lens is a much more accurate way at how do we deal with the challenges and the opportunities that we face. Naturally, when we think about this journey from a chronological lens of maternal and pediatric health all the way through our adult healthcare and well-being and ultimately our geriatric care. But like everything in healthcare, it's also not that simple. Our journeys are complicated by chronic conditions, often defined by our determinants of health, our genetics, behavior, environment, physical influences, medical care, and social factors. So without further ado, I'd like to do a couple housekeeping items here before we introduce our speaker. First, to respect the delivery and content of our speakers, please take time to silence your cell phones and electronic devices. Restrooms are located at the end of the hallway down to the right, past the other table if you go down there. Breaks and lunch will be available in the foyer. As a reminder, please use the elevators to enter this event near the front of the building. The elevators you saw by the breakfast station only go down the lobby and do not go back up. So that's a one-way ticket, so don't take that elevator. We do understand that everyone's busy, so if you have to take calls, please step out of the room, take them in the foyer. And also please keep your phones on silent. Complimentary Wi-Fi is available, and I think there's signs on the tables for each of you to take a look at those. Please do tweet, LinkedIn, Instagram, and any other social media platform. Use the hashtag SPES 2024, hashtag putting patients first for your social media posts. And please connect with the National Health Council on social media channels. More information is available on the NHC Reg Desk. We have members of the media attending, and they are identified by a black ribbon on their badge. We also have a caregiver room located on the 14th floor for nursing mothers. The room has locks and mini fridges. If you need a room, please stop by the NHC Reg Desk. And very importantly, we do have these nice hashtags, QR codes on the table. Please use these. These are our surveys. Give us some great valuable feedback on how we continue to enhance the programming. So let me go ahead and dive into our keynote speaker introduction here. So I'm thrilled to introduce Dr. Kapil Parakh, author and senior medical lead at Google. Dr. Parakh has launched products that reach over 1 billion people and pioneered partnerships with a range of organizations, including the World Health Organization and the American Heart Association. Dr. Parakh is also a practicing cardiologist, teaches at Georgetown and Yale University, and in prior roles, Dr. Parakh served as White House Fellow and is co-founder of Health for America, a nonprofit on health innovation. His book, Searching for Health, The Smart Way to Find Information Online and Put it to Use, helps patients find evidence-based information online and insights into what they can expect from a visit to the doctor or hospital, and how to make decisions about surgery or other treatment, what tests doctors order, which symptom trackers are really effective, and what questions to ask about medications and supplements. Today, Dr. Parakh will be speaking on artificial intelligence and its use across the life continuum. In threading last year's theme, when we talked about patient empowerment in the digital health era, we set the perfect stage to continue our discussion on this topic and take charge to make AI work for everyone in the healthcare system that is trustworthy, responsible, and equitable. So without further ado, I'd like to welcome Dr. Parakh to the stage.
Thank you. Appreciate the generous introduction, and thank you all for having me. So my job is to, in 20 minutes, talk about AI technology and how that wraps into patient engagement and all the important work that we're doing around that, as well as healthcare in general. So super easy. My disclaimer is I'm a full-time employee at Google, and so what I'm saying here is my own opinions, even though I represent Google. I'm an adjunct professor at both Georgetown and Yale, where I teach and do research. I'm a cardiologist. I see patients 1 day a week at the Washington, D.C. VA Medical Center. And I wrote a book called Searching for Health, which is really about bridging the divide between what patients experience when they search for information online and how they can more effectively take it to the doctor's office. And for those in this audience that are working in this space, you can check out the website searchingforhealth.org. It has some free resources and stuff. So just as a broad overview, AI in healthcare, I think we're at a tipping point where we're going to see a big impact of AI in all sort of across the healthcare spectrum. Whether it's products that are being used to create new medical pathways or improve diagnoses or research or predictive modeling, all the way down to imaging and other sort of applications. And this is just the beginning. The pace of change in this field is astonishing. And somebody asked me just before I gave this talk that if there's something I could leave this community with, what would that be? So I'll start with sort of like the bottom line up front. If there's something I can leave you with, it is try the tools out for yourself. I'll give you a quick anecdote before jumping into sort of the main talk to drive that point home. Almost a decade ago, maybe 7, 8 years ago, I was working on Google Search, and we launched a product called the Knowledge Graph. It's a little panel that gives you a summary of information about a disease. It was a big deal at the time, the first time Google had produced information as opposed to just sending people different places. That's the product that reaches over 1 billion people today. One of the things I wanted to do was to incorporate in that something that a patient could use that's sort of more guideline-based. So as a cardiologist, I care deeply about the cardiology guidelines. So we figured out a partnership with the American College of Cardiology, and we went through their guidelines and say, hey, if somebody's had a heart attack and they look at the panel that says heart attack, what questions should they be asking their doctor? This is sort of like I took inspiration from like, hey, ask your doctor about Viagra. I'm like, no, ask your doctor about a statin after a heart attack because that will save your life. But nobody does that. And so the idea was, how could we distill the guidelines into a few questions and give some details on why you should be asking those questions, like statins lower mortality, and so you should be asking your doctor if you're not on one already, things like that. It took us months of work to work with the ACC to consolidate, like essentially squish 500 pages of guidelines into 5 or 6 important questions and facts. You can do that in 5 minutes now with AI. You can upload that to an AI tool of your choice, Gemini by Google, ChatGPT, whatever, and say, give me the 5 salient points from these guidelines. And then you can have a clinician like me review that and say, like, hey, does this make sense? And then you can tell the tool, hey, make this at a 5th grade reading level. Make it funny, make it engaging. And you could do all of that in just a few minutes. So the message I would leave you all with is just try these are all free tools, try them out and find ways to incorporate them in your work. And what you'll find is that once you try them out, you'll see where their strengths and weaknesses are. And then when you're talking to researchers, policymakers, patients, whatever work you're doing, you'll be able to have a more informed discussion about AI than if you hadn't had this experience. So with that, I just want to give you a little bit of a sense of what Google's doing in this space and sort of more generally across all of our products and how they might be useful in your world. So Google Health is a company-wide effort to help billions of people, and we believe that everyone should have access to health resources, and we sort of define our work in 3 buckets: consumers, caregivers, and the community at large. So consumers being sort of folks who come to search or YouTube, things like that. Caregivers being not just physicians, but also nurses and advocates and folks like that. And then the community sort of describes more of our public health efforts in this space. It's a bit of a busy slide, but these are logos that many of you will be familiar with. So things like YouTube is a major source of health information in addition to search. We try to be responsible with ads to make sure there's misinformation that's taken out of there. We have devices like Fitbit and Pixel, and then an ecosystem that Health Connect, which is a platform that connects all of this information across. We also have a number of enterprise solutions more targeted towards caregivers, whether that's our cloud services, Chrome OS. We have all this AI work around imaging, as well as our devices that end up in more enterprise solutions. And then the community work sort of spans a whole range of things, everything from grants and investments in community organizations and partnerships, health equity research, as well as creating tools that make it easier for people to build stuff. So Open Health Stack allows you to develop health applications more easily because it has all the building blocks. And then we also do things like make some of our tools more available. So like we're one of the first that you can get a heart rate from a smartwatch, but I helped launch this where you can actually get it from a phone and even cheap Android phones. So like kind of making that kind of technology more equitable and available. And the health equity focus is really important to us. We have a small but mighty health equity team, and we try and infuse that in all of our different efforts. The other thing that we focus on is partnerships. So we firmly believe that we're not going to reinvent healthcare ourselves. In fact, one of the first things I did when I joined Google was help them partner in launching those knowledge panels with Mayo Clinic, and then I've worked on a number of partnerships since. And instead of like trying to become a doctor or become the next healthcare institution, we believe instead in partnering with them and trying to figure it out. And that's everything from health plans to providers to pharmaceutical industry and med device and so on. And we use our tools through these channels, through these partners to eventually reach lots of people and improve health. So going back to AI, I wanted to, before I go into the specifics, I want to take just a minute to give you a broader overview of what AI is and demystify the black box just a touch. So most of us, when you hear AI, you sort of hear a number of terms thrown around, things like machine learning, natural language processing, generative AI, foundational models, stuff like that. And it all sounds very confusing and technical. And as a cardiologist, I had to figure all this stuff out. I have no technical background. And so the way I think of it is like if you go back to high school and you remember sort of the dots on a curve in y and x-axis, and you put a line through them, and that line sort of describes the relationship between those dots, y equals mx plus c. And we know that where the dots are dense, that line is a more accurate representation of that relationship. Where the dots are not so dense, it's not such a good representation, it's more of a guess, right? And the line just keeps going, so even if the dots fade out to 0, you'll still see the line going. So even though we have no or very little information, we're making a guess of how things are going. And that's how things started in mathematically in this sort of world. Moved on to multivariate modeling, so many of you know Cox regression and logistic regression, where you can put many variables in. It then went on to like a set of rules, so people figured out how to like program machines in rule-based environments like chess. And you have the competitions where machines could be chess grandmasters and things like that. The next level was, what if there were no rules? How could you figure stuff out? And so what they trained the machines to do was how to just recognize patterns. And the way we see this most nowadays is, if you have a phone, you pull up your photos, doesn't matter whether it's an Android or Apple, they all do it. It'll show you pictures, and it'll say, hey, do you want more pictures of this person? And it might be you, it might be your wife, your kids, or dogs, or whatever. But how does it know that you never labeled all your photos? And in a logistic regression model, if you had to do this, you would have to label all of them. The reason is it recognized the pattern, and it figured out what that pattern was. These are all you, these are all, and they all kind of look alike. And so it created a pattern without any rules, as it were. Just like the dots, if they're not enough of one variable, so these models are actually very poor initially at African-American faces. And over time, that's because the initial models were not trained with dark-skinned people. And over time, they get better with that. And so that's how you can see like the same lack of data coming across in these bigger and more complicated models. The most recent examples of this is generative AI, where essentially, instead of finding patterns in pictures, you're finding patterns in words. And they can predict the next set of words, as in when you're typing email, it sort of tries to complete the sentence for you. Or now you can ask a question, and it'll spit out an entire answer because it's figured out, it's essentially ingested the entire internet and figured out, like, these are the patterns. And so when you ask about, give me the summary of the heart failure guidelines, it knows heart failure guidelines, these are the documents that have those, and tries to summarize them because it's figured out those patterns. Now, we all know everything on the internet leads to cancer. Just checking if you're awake. So if you have a model that's trained only on the internet, it's the same thing, right? Like, if you have a rash and it turns out to be nothing, you go about your day. If you have a rash, it turns out to be cancer, you go online, you blog about it, you type everywhere, like, this rash is horrible, it's cancer. And then if you mine your model on the internet, all rashes are cancer. And so it's as much as it's a joke, it's a real problem, where if you have a general model that's just trained on the internet, you have those kinds of biases built in. So things to think about as you sort of come across these models, and try and go back to those like basic principles, and they still apply. So here's 3 specific examples. So reducing clinician burnout and boosting efficiency. So this is really interesting. So one of our partners actually does this work, but essentially they use our tools to record patient conversations with physicians, and they transcribe them, produces 2 outputs. One is for the clinician, so that you don't have to sit and type a note, which I can tell you from personal experience is painful. And then 2, almost in near time, provides a summary to the patient, after visit summary. Here you go, here's what happens, here are the recommendations. A number of times I've had to write down, like, sir, remember, you're going to take this, you're going to do this, right? It's all done for me. And I can also double check, make sure, oh yeah, I actually got it right, or no, missed a point, and then you're done. And so that brings in this kind of efficiency and collaboration into the appointment that you don't have the time for. And so that's sort of one example of how this could be used in that way. We can make the same way, sort of like we're talking about these tools that can provide the guidelines. There's another company that recently spoke with that uses AI tools in this way, where they essentially do the pre-screening for you. So anyone ever fill out those forms, beforehand? Now you can do it with a chatbot in a much more intuitive and intelligent way. So when I get a summary of, hey, what did you come in with? It's crisp, and it's in a format that I understand. So it can, part of my visit is data gathering, and part of my visit is clinical reasoning, and the other part of it is like communicating with the patient and telling what's going on. If you can compress the data gathering part, then you have more time for the others, right? Ask your doctor. Isn't that what we tell everybody? Well, I got no time for your questions. this we can make time in patient visits. So it's kind of really powerful. And then there's a whole bunch happening around AI and research. We just announced yesterday that a part of Alphabet, which owns Google, it's called Isomorphic Labs, mapped every molecule known and then the interaction of every molecule known, biologic, with every other molecule known in the body. And so now you can imagine like drug development where you're trying to figure out, okay, I need a molecule that affects this receptor, but then doesn't affect anything else, right? No side effects. And now you could actually model those interactions through AI and speed up drug development. And that just happened yesterday. So like, I mean, it took a while, but like, that's how fast the field is moving, is my point. So I think YouTube is another important platform for you all to be aware of. So we're helping to raise supportive stories. So one of the wonderful things about YouTube is, so one, it's just a great way to educate people. You don't need to be able to read. It overcomes literacy barriers. You can, especially with AI, you can actually now translate it into multiple languages. So you can overcome language barriers. But then it's also a great way to add empathy and emotion into a very sterile experience, right? Like medicine it's a frightening thing to go through diseases and get all this like sterile information from the doctors, and so it can help humanize it. And so we've enabled this sort of infrastructure to elevate these stories, but you can actually just use these tools to then find your own stories and help elevate them. You know, back in the day, if you wanted to create an engaging video, you'd have to engage like some production company and do all of this stuff. You know, for a fraction of that price, you could find a YouTube creator that's powerful in your micro community, whether it's the African American community, whether it's a gay community, whatever, who's popular in that, and then say, hey, we'll pay you the money, we'll give you like what their guidelines are, like this is the content, you go make it, and boom, you have this amazing content that can be used. Conversely, if you have a group that's marginalized that you want to highlight, you can record them, let them tell their stories, and then when people see that, they can relate to it, right? So really powerful stuff. And then we're doing all sorts of AI things to make that even easier. Some of them are just fun, like you can add like John Legend's voice to your things, or you know, make it interesting. But then we'll also make it easier to search and discover and engage. These are the knowledge panels that I mentioned earlier. We're trying to make them more robust and easier to find and more credible. Like where if you want a doctor that takes Medicaid, we like essentially used AI to call every doctor in the country, and the robo voice said, hey, do you take Medicaid? And when they say yes, they get added to the directory, and so now we have the ability to do that, which is pretty cool. And so, you know, large language models, that's the other acronym that you'll hear a lot, LLMs. These are essentially models that, instead of finding patterns in pictures, find patterns in words and spit out really long answers. But they can actually help you, like I described, create patient education material, simplify, translate it. The other thing they're really good at is translation. I think of this as, yes, you want to be able to translate English to Spanish, but you also want to be able to translate medical to patient. And so they can be used for that, which is really cool. You can actually personalize and tailor some of these, which are interesting. So you can have the model say, like, pretend you're a nurse in Baltimore, explaining to a former steel worker what heart failure is. And it will try its best to sort of emulate what that looks like based on what's found on the web. And if you, again, like editing content is often, not always, but often easier than creating content, the tyranny of a blank page. So these are the kinds of ways you can use this to come up with interesting things. One of the other things that we did in a prior life at Hopkins when we created patient education material around heart failure, I'm a heart failure cardiologist, so you heard me say that a lot, is we had this booklet, ended up being 50 pages because patients just kept asking for more and more stuff. About 60, 70% of it was dense information, like these are the drugs, these are the medicines, these are the devices, these are the diet things, all that stuff. About 30, 40%, we added stories of people. And if you don't have the stories yourself, you can ask the model to create one. Like, describe this to me as if it was a fairy tale. Make it dystopian, make it like whatever, and it will do it for you until you find one that resonates with your patient population. So again, really interesting applications there. I'll move on to some of the other sort of parts of what we do. So Health Connect is a platform that we have that allows you to connect all sorts of devices. So if anybody's working on apps, trying to help patients connect their data across different systems, this is something that you can use on the Android side. Apple has something similar called HealthKit, and it allows you to really connect information in one place for patients across a lot of different apps. If you're looking at wearables, in addition to all the AI stuff that Fitbit's doing, it's just like a great way to engage people. So one of the things I found both personally and also in some of the work we do in terms of partnering with folks really all around the world, this an example from the NHS, is people get discharged from the hospital with after a heart attack, and they had a program where they'd give them Fitbit devices and do some remote monitoring of their steps and like heart rate and stuff like that, but also would call them up about their medicines and smoking and all that sort of stuff. And the patients sort of went from this environment where they were monitored 24/7 to sort of hanging out at home and waiting 2 to 3 weeks for the next appointment. And it was a frightening time for the patients because they're like, I was being like super checked upon, and now like I'm on my own. Having the device made them feel more connected to the hospital, and it was really interesting that not only did they comply more, like did they walk more because they knew somebody was looking, they took their medicines, their cholesterols got lower, their smoking rates plummeted. Again, because they felt that they were being sort of watched and cared for in a way that they hadn't felt before. So much more than just a device, right? So sometimes the device can be the thing, the shiny object, but it's a program that you put around it that can be pretty powerful. The other thing that's nice about it is there's this whole concept of like sick work. Like when you're sick, there's a certain amount of work you have to do for your illness. You have to check your blood sugar if you're diabetic and watch your diet and all this stuff. And that sucks because I just want to be normal and live my life. But whereas if you're like talking to somebody about their steps or their sleep, that could be, yeah, I'm like competing with my granddaughter. We had a good, thing, and she's better than me, but I'm catching up. It suddenly becomes more fun and engaging, and it's no longer, and then you can sort of casually bring up the necessary sick stuff too, but it becomes an excuse to engage with people in a way that's not just about their disease. They're more than their disease, which is really powerful stuff. And then just for fun, like we've done stuff with, Google has this arts and culture app, and they've partnered with various health institutions to bring some of the, like a brief history of vaccination. They've done some stuff around tropical medicine and hygiene. But I kept this on because I think there's a component of fun that is often missing in healthcare. And, yes, diabetes can be fun. Like it is a serious disease, but you can also have fun with it. Like when I was running the heart failure clinic, about once a quarter we had a party where we just invited all the heart failure patients. It was low salt food. But just got together, and like the nurses and the doctors, whoever were available, and like everybody just hung out, and they appreciate that so much because they could just hang out and talk, and not about heart failure. I mean, it was a thing that everybody had in common, but it wasn't just about their disease. And there's ways for technology to serve that role as well. I would be remiss if I didn't mention some of the other ways that AI is moving things forward. I know this is across the lifespan, and I'm sorry I haven't touched too much on it. I think part of it, sort of as you're transitioning from yesterday to today, like I think of myself as a sandwich generation. So there's stuff I have to do for my mom and my mother-in-law and others. Like anyone who's sick calls, that's kind of life. But then I have to also worry about my kids. Like I'm taking my daughter for a blood test this week and stuff like that, right? And oftentimes that's women get saddled with that responsibility and have to take care of both. And technology can play a role in both ends, right? Like all the young kids watch videos all the time. That's kind of all they do nowadays. And then on the older end of the spectrum, one is I think age is often used as a way to discriminate people against technology. Just assume, hey, you're old, so you're never going to use a smartphone or a tablet or a wearable or things like that. And the data shows that's just not true. Old, whatever you described old as, some people call me old. I'm like, not yet. Hopefully not yet. There's people of all ages use technology. What we found in studies is that as you get older, people have less tolerance for tech support and being their own tech support. When you're young and you can't get your phone or you can't get an app to work, you go online, you Google it, and you watch a YouTube video, and you figure it out till you can do it. when you're older, you're like, this thing doesn't work, I'm kind of done. And so like, when you think of those things, then you can design programs that like build in the appropriate levels of support so that they can use technology, right? Or like simple things like just big font, right? Like when you're older, your eyesight's not quite the same. And so like, instead of make them take out their reading glasses every single time, just make the font bigger. So anyways, and so I haven't sprinkled it as much through my talk. 20 minutes is just isn't long enough. But I hope some of these themes come through as I'm speaking. So AI in imaging is a big deal. So much like your images in your smartphone, we can actually do a lot with images in a way that we just couldn't do before. So and there are papers in both Nature and Nature Medicine and a bunch of impressive journals that look at many of these areas. So diabetic retinopathy, we looked at, you take these images and you say, hey, can the machine code them as a stage of diabetic retinopathy? And you compare it to 6 retina specialists. And what you find is that, one, the retina specialists disagree a lot, which is a little scary. But the machine does better than all of them combined. And the same thing with mammography, you find sort of much more detection of cancer than what a radiologist can pick up and things like that. We helped a partner in the US, I think it's Mayo, they're working on radiotherapy planning, so you can actually plan the field of radiation with AI so that it doesn't hurt the neighboring organs, things like that. And then we can take a lot of this data at a population health level, right? So we can look at things like genomics, just what I described earlier from what we've released. We can do mobile sensing and track like how populations walk across the world, and we've seen declines over COVID, and then they're bouncing back up, things like that. Public health, we're looking at climate change and its impacts on health, and by all these massive data sets that have all of this information, but with AI tools that can now analyze them. And then finally, we're supporting the community through research investments and grants, and so we work with a wide range of organizations. We do something called the health equity grants and give out grants to people working with underprivileged communities in different ways. Oftentimes it's also with free devices or cloud or things like that to help them with their research and things like that. And we're trying hard to help with social determinants of health where we can through a range of programs. What I want to leave you with is we are in an era of absolutely incredible tools. Like what we can do today, even like 5 or 10, I've been at Google 10 years, and in that time I've seen this incredible progression of technology. The question is, how will you use them to change the world? I'll stop there.
Thank you, Dr. Parak. Excellent. So much to think about. So as you all are thinking about your questions, we have a couple microphones here, so feel free to kind of line up while I'll give our first one here. So this was kind of, could you talk a little bit about how patients and patient groups could get started to become more familiar with AI? So you covered the landscape here, but where do they dig in and start off?
Yeah, no, absolutely. So sort of like I alluded to in my talk, which is like just try it. And the simplest tools to do would be like Gemini or ChatGPT. And just go online and start asking them questions. Ask them medical questions, ask them stuff you're curious about. You know, one of the things I did was I had a bunch of random ingredients, and I said, give me 3 cocktail recipes with this, because we had people coming over. Some were not so good, but you get the idea. And you start to get familiar with the ways the models work and the ways they break. So some of the ways they break are something called hallucinations. So going back to the dots, right, where the line continues and there's no dots. So for a model, it's really important for the model to have a coherent answer to your question. And the emphasis there is really on the story rather than the facts, just like any fisherman. And so if you think about it, the model has to get the story right. And so where it doesn't have facts, it fills them in. It just adds stuff in. Now, you all are experts in your spaces. So wherever you have expertise, those are the kinds of things you ask. And you're like, oh, I know that's not true. And that's correct. Oh, that's impressive. And that will get you much more comfort in what those models are good at in your space. And so then when the question comes up, like, how do we use AI in patient engagement, in this chronic disease, whatever it is, you can have an informed opinion, like maybe you don't know everything, but you tried some stuff out, and you can see, one, where it did well, and two, where it fell apart. And so on both ends of the spectrum, you can be useful in those conversations.
That's great. So getting back to that whole beginning of start playing with it, start using the tools to start seeing the impact.
That's exactly right.
That's great. I think we have a question over here.
Hey.
I'm Alicia Schultz-Lloyd. I'm from Merck, and I have a question sort of based on what we learned yesterday. Dr. Rabi talked to us a lot about how the process of healthcare prevented her from giving healthcare to a subset of patients who just were sort of shunted out of the process because the process was designed for billing and reimbursement. And then Taylor Hoffman shared with us a story of her own personal journey where she was not given the medication she wanted because she's a woman of childbearing age. And her doctor made an assumption and just flat out wouldn't let her use, even though she didn't want to have children at that time, made an assumption about she can't have this. In your knowledge panels, as you're digesting guidelines, that sort of reinforcement will continue to occur, right? It'll say, oh, this person who's talking to me and asking me for treatment options or what they should discuss with their doctor is a 24-year-old woman, therefore they shouldn't have access to these medications, and sort of remove it from that person's options. So how are you making sure that the bias that we already see in the system isn't reinforced? Or are you using live patients or patient advocacy organizations to check what's coming out of those panels to make sure that we're still seeing the individual with the condition and not just treating the condition and making assumptions about that individual?
Yeah, so very powerful questions. So just sort of a little more context there. So the knowledge panels are more geared towards the average user on search, so they're not geared towards professionals. The way we created them was we started by just mining associations across the internet, and medical literature. So we had a starting point. And then we ran it through a series of physicians who checked them for accuracy and weighted them. And then after that, we had the Mayo Clinic re-review all of that. So by the time it was published, an average of 8 to 10 physicians had touched that data. And so, to the extent that we can, we try to provide what was like a consensus view in a topic. And then even then, there are times we get it wrong. And so we have feedback options because these reach a lot of people. So I'll give you one specific example. And this was eye-opening for me personally. One of the things we added to the knowledge panels was an illustration that it showed empathy for the disease condition. So somebody with fatigue syndrome, tired while their friends were doing something, things like that. And we tried to incorporate in there some preventive suggestions or public health-ish messages. So for the flu one, we showed somebody getting vaccinated, but then also somebody else coughing, and sort of the idea that vaccination is preventative. For the lung cancer one, we showed somebody smoking. And we got a lot of pushback because many lung cancer patients have never smoked. And so we changed the picture. We're like, oh, you're absolutely right. That was not very thoughtful of us. And so I think whenever you're creating these tools for entire populations, it's hard to individualize. And so one is you have to have processes that allow for refinement and feedback and that sort of thing, which we did. But then at the patient level, this is something I wrote about in the book, and I think it's really about a duality of finding ways to empower patients to get a second opinion, to not settle for what the conventional is if they don't buy it or if they believe in their risk benefit that's different. Because in the end, we're never going to be able to design for every eventuality. And so it is this combination of sort of clinicians doing their best and then patients also being empowered to seek second opinions, to seek other treatments. Sometimes allopathic medicine doesn't work, and there's all sorts of complementary medicines and so on. So long answer, it's a complicated space.
That's a great summary at the end there. All right, we have another one over here.
Thank you. Thank you for a very informative talk. I thought it was great. This is more of a comment than a question. I'm with the Orthopedic Research and Education Foundation, and last week we had a symposium, and a resident from the University of Chicago did a study comparing the AAOS guidelines, which I used to be the director of research at AAOS, and I was involved in developing these 10 guidelines. And they took actual cases, and they had the AI make recommendations for these cases, and they compared them to what the guidelines were. And it came out that there was, the AI agreed with the guidelines in over 90% of the cases, which I found very encouraging because, as you say, there's individual differences. What I thought was interesting was that they also then compared what the actual physicians at the University of Chicago, the surgeons, had done, and it only agreed with the guidelines 79%. So I thought that was the bigger problem.
Yes.
But anyway, thank you for your talk.
No, I love you mentioned that. So I think that's like sort of, I'll get to the next question in a second. I think there's an important point to consider. So in medicine, we all often believe in first do no harm. The problem is harm is being done. One of the leading causes of death in the United States is medical error. I lost a friend to medical error. It's a big deal. And so if we hold AI systems to these impossible standards of being perfect, right, we will never have progress because we'll be stuck with imperfect humans.
That's great. Last question over here.
Yeah. Thank you, Dr. Prock. Great talk. Really enjoyed it. My name is Trey LaRosa. I'm with the Foundation for the National Institutes of Health, and I also have cystic fibrosis. And something you mentioned that I'm really grateful for and really passionate about is the importance of developing material that's patient literate, patient centric, and really making sure that it's if we're creating material that are only for other physicians or other scientists, it's really missing the mark. And while I think that there's a lot of power to AI, and I think that it's really important that we focus on it as a complementary tool as opposed to something that's going to replace a lot of people, one thing that I think could become a problem from the patient perspective is if all the AI is generating the patient literate material, it sort of it removes the role of the patient in developing that material. And something like patient perspective is very nuanced in different communities. Some communities prefer very people-centric language. Other communities have different preferences. How do you foresee that we will make sure that we're developing AI in a very ethical way in something like this space where we're developing patient-literate material?
Yeah, no, absolutely. I mean, I think in my mind, this is the beauty of like these tools with a group like this, right? Like that's the perspective you all bring. And whether it's your organization, whether you're running a private company that's trying to create these materials, like however you're funded and supported, if your materials are more engaging and connect with patients because you have that perspective, which a generic AI tool doesn't, you will get ahead. You will see sort of progress. And so I think it's sort of like a knife. You hand it to a surgeon or a thief, and you get different outcomes. So AI is like a blanket tool. It's really who uses it and in what way.
All right, well, that concludes our session. Thank you so much, Dr. Parak. Very engaging.
Thank you all. Thanks.
So I tried to ask an AI engine, I said, how do you raise my 3 teenagers? And it said, good luck. So, but anyhow, again, excellent session. Thank you so much. I'd like to now go ahead and welcome up Tina Aswani Aprakash and the esteemed panelists of Fearless Women. So excited about our next panel.
Thank you, Devin, for the kind introduction. I'm here on behalf of Summer Consulting, a research firm owned by a woman and minority, and we focus on bridging the gaps between patients and healthcare professionals within the pharmaceutical industry. I am also a Crohn's disease patient advocate. I have founded the blog called Own Your Crohn's and co-founded a patient and healthcare professional-led nonprofit organization called South Asian IBD Alliance. It is with great pleasure today that I introduce you to an amazing panel of, like Devin said, fearless women. We are going to be talking about disrupting the paradigm realities of adult-based care for women's research. So with that, I'd love to introduce you all. I'll start with Barb. Barbara Kalura has served as the president and CEO of Resolve, the National Infertility Association, since 2007. She is a nationally recognized expert on infertility and the family building journey, with a special emphasis on advocacy, public policy, and access to care. Barbara has worked with the World Health Organization on infertility definitions and clinical guidelines, with the American College of Obstetrics and Gynecology on their clinical definitions for infertility, and served a 4-year term on the Advisory Council of the National Institute of Child Health and Human Development at the NIH. I would also like to introduce Dr. Elizabeth Franklin, who is the head of US Public Affairs and Patient Advocacy Oncology at Sanofi, where she partners with the US advocacy community to advance innovation, ensure access, and improve health. Dr. Franklin has a deep passion for social work and was drawn to this space after witnessing people being left behind and systems that resulted in inequitable care. These values have driven her for almost 2 decades in oncology patient advocacy, public policy, research, and executive positions in corporate and nonprofit settings. Now, Ushma Patel is the Director of Patient Engagement at the Innovation and Value Initiative, where she oversees the IVI Patient Advisory Council and ensures the patient voice is captured in all research initiatives. She ensures that patients are truly partners in the research process. Ushma is a preeclampsia survivor and a caregiver for a child with rare disease. She has served on many patient advisory councils, including the Preeclampsia Foundation and Duke Pediatric Congenital Heart Center. Ushma is passionate about patient collaboration and empowering women to trust their instincts. So with that, I'm very excited to get us started on our panel. I wanted to ask you all, can you speak to your stories? Can you tell us a little bit about what has led you to this work and any patient experiences that you might be willing to share? Can I start with Barb?
Sure. Hi, everyone. Resolve, the National Infertility Association, by the way, is a proud member of the National Health Council and has been for many, many years. If you're thinking about membership, let me know. I'd love to talk to you about how great it is. So Resolve was founded in 1974, so I did not found it, although it was founded by a woman named Barbara. I came to this organization through my own infertility experience. I live here in the Washington, D.C. area. My husband and I were struggling with infertility. I gained a lot of resources from the organization. So I was a recipient of Resolve services, and then I'm a serial volunteer. So I raised my hand and started volunteering for the organization. And then in 2004, they moved their national headquarters to the DC area, and I joined the staff. And so I come to this with a tremendous passion for our mission because of how it helped me, but also just the work that I've seen, the impact that it's had on so many over the years. So I always joke that I'm the least experienced person on our team because they all come with all this amazing nonprofit and health experience, and I'm just a patient advocate, as I like to say.
Barb, you're too modest. Thank you for sharing. I really appreciate that. How about you, Dr. Franklin? What sort of led you to this work, and if there's any patient experiences that you'd like to share?
Yeah, during our prep call, it was interesting, and I don't think we planned it this way, but we were talking about our personal experiences, and you're going to hear 3 very different perspectives. You're going to hear about infertility, you're going to hear about the birthing and mother perspective, and then I'm going to bring a little bit of a different perspective, which I've never really shared publicly, so I'm happy to share it. But I want to start with the fact that shout out to NHC and the Press Club for these chairs. And I'm dead serious about this. Whenever I plan a panel, if you put women on stools one more time, I'm going to burn the place to the ground, right? Because thank you. A, these are comfortable, but B, as Tina has on a skirt, don't put women on stools. And so part of why I want to talk about that, so I've been suffering from fibroids for the last 15 years, and I'm very serious about this. There's a reason I never wear skirts. And it's because I've had such intense issues with fibroids that I have bled out on the metro. I have bled out in the office. I've ended up in the GWER thinking I would need a blood transfusion because that's how much I've bled from a place that no woman wants to be bleeding publicly. And so the reason that I bring that up, it's funny about the stool thing, but I don't wear skirts because I'm terrified that I'm gonna start bleeding at any moment. In 2012, I had my first fibroid, and it was the size of a grapefruit. In 2017, I had my second surgery, and it was the size of a football. My doctor said it was the largest fibroid he'd ever seen. And I bring it up especially because I've known my entire life, my whole life, that I don't want children. I am 100% sure I've never wanted children. I'm child-free by choice. I love that this panel is so diverse, and we're gonna talk about different perspectives towards kids. But in 2012, when I had my first experience with my fibroid, I said to my doctor, I'm turning 40 this year, so I was 28 at the time, and I said, I'm 100% sure I don't want kids. Can I just have a hysterectomy? Leave the ovaries, I won't go into menopause, but I 100% know I want a hysterectomy. And they said, it's not even a conversation, I won't do it, right? I said, okay, I'm 28, fine, I'll have the myomectomy, which was an awful, painful surgery. I hated every second of it. And then in 2017, when I started bleeding out again, I asked my doctor, a different doctor this time, if I could have a hysterectomy, and he said, and I quote, "It would be borderline unethical for him to perform a hysterectomy on me." Not sure. I said, whatever paper I need to sign, I'll sign. Please, I want a hysterectomy. No. So right after that surgery, I had immediately more fibroids. So my body has expelled my IUD because the fibroids are pushing out the IUD that I have because I can't get a hysterectomy, right? So again, it's just, I think, a really telling journey of a woman not being listened to. Nobody believes that I don't want to have children. So I'm really excited that I'm turning 40 in a month because someone might finally pay attention to me, right? Now I'm in this interesting period where I'll be old enough to be paid attention to, but at what point do I become old enough that people stop listening for different reasons, right? So we'll find out, but that is my personal journey. I should have said this before I told that story. I work for Sanofi. None of this is on behalf of Sanofi. But I'm excited to talk about oncology too, because I think female cancer patients are often not listened to. I have a special place in my heart for gynecological cancer patients, especially because when we're in pain, when we share things, we are brushed off many times and not taken seriously and not paid attention to. And so these are the values that drive me. Really excited to talk about and stand up for women's health, and really thrilled to be a part of this panel. So thank you to my friends at NHC for inviting me.
Thank you so much, Elizabeth. And I think it's really important for us to just, honor the fact that you've shared such a personal aspect of your story, and it's really hard to do that. And
Thank you.
It's almost re-traumatizing sometimes to do that.
It's definitely traumatizing for the people on the metro.
Ushma, would you like to share what sort of led you to patient advocacy and a little bit of your journey?
Absolutely. Thank you so much. I'm so honored to be here today with such an amazing group of women. First, I want to thank National Health Council for giving me this opportunity to be a part of the panel and just bringing so many passionate people together in one room. It's just amazing. So I'm with the Innovation and Value Initiative, also known as IVI, and we are also a proud NHC member. IVI is an independent, nonprofit research organization working to advance the science, practice, and use of health technology assessment or value assessment. So I'm here today, though, to share my patient perspective and caregiver perspective. Prior to IVI, I worked in several nonprofits developing patient engagement tools and working with hospitals on how to develop patient and family advisory councils. So I was already doing the work, but I know, I'm sure some of you also agree with this, but once you become a patient yourself, you kind of see a different perspective of the healthcare system. So in 2013, I was put into the driver's seat of this journey called motherhood. I buckled up. It was definitely a bumpy ride. I became pregnant at 29. I was relatively healthy and active, and we got pregnant quickly, which is just such a blessing because I know that not everyone is so easy to get pregnant. And it was not the easiest pregnancy. I had a lot of nagging symptoms. I had morning sickness and headaches, and just really felt very, very tired and felt off. Like I knew that something was wrong. And being in the space that I was in, I would go into the doctor's office with like a long list of questions and really try to work with the clinician. And honestly, they would tell me, relax, you're fine, everything's normal. This is all part of a normal pregnancy. And so I would go off on my way. Around 35 weeks, I started developing swelling in my face and my legs, and again, just knew that something was off. And I actually saw a social media post about the symptoms of preeclampsia and HELLP syndrome. And so it just really, it struck a chord. I was like, oh my God, maybe this is what I have this whole time. And so I went to the pharmacy first to check my blood pressure. It was very high, and I called my OB, and they asked me to come into the hospital. I did not bring a bag with me. I brought nothing, really. I thought that I'd be going home that same night, and they kept us for monitoring. And the next morning, they diagnosed me with severe preeclampsia, HELLP syndrome, and I delivered my baby girl 4 weeks early via C-section. So throughout my stay at the hospital, my symptoms continued, and I still had that headache and still had high blood pressure. But the doctors again said, just relax, honey. Just, try to get some sleep. Sleep when the baby sleeps. And that was really hard. And my daughter was also being monitored for jaundice and a heart murmur, which again, they said was really normal and common. Little did I know that things would go south from there. So on day 5 after delivery, I was still in the hospital, and I again knew that something was wrong. And so I pleaded to the charge nurse, please come inside and check on me. I just don't feel right. And within minutes, there was a whole team of staff and of doctors around my bedside. And they took me down for a CT scan, and it turns out that I had suffered a subarachnoid brain hemorrhage, which is bleeding on the brain, and I had a stroke. And at the same time, my baby was taken to the NICU for oxygen issues. And so I had no idea what was going on. I had never even heard of preeclampsia before this, and I did not know that it could develop into further complications. And so I was taken to another hospital 30 miles away because my case was too complex. They did not allow my baby to come with me, so we were separated for almost a week, and that was really, really hard. I would pump milk, and my husband would take it to the other hospital. And so it was a really, really rough experience into parenthood. It's just not what I expected. So once we both finally came home and were discharged, the struggles continued, right? I was recovering from a stroke, a C-section, trying to breastfeed. I mean, there's so much pressure put on a new mom. And also, just naturally, given the traumatic experience, I felt depressed. I felt like robbed from this birth experience that I wanted to have. And my daughter struggled to gain weight. She was, spitting up all the time. So we were in and out of the doctor's offices and in and out of the ER. And finally, after a couple of months, she was diagnosed with several congenital heart defects that completely went undiagnosed during my entire pregnancy. So she had open heart surgery at 8 months, eye surgery, and then around 2 years old, we finally got genetic testing results back. So she has a rare disease. It's called Noonan syndrome. So, parenthood has been a rough ride, to say the least. And I want to say I was able to have another baby, thankfully. And I want to say this because I felt empowered the second time. I had the tools to help me. I had a high-risk MFM that I really trusted and that I worked really closely with. I had a doula, which she has a special place in my heart and was able to give me that full-term VBAC delivery that I was, looking for. So that's my story.
Thank you for sharing, Ushma. And I think you make some excellent points about going into motherhood with, sounds like a lot of trauma too, from the childbirth experience. I think it's important here to highlight the trauma, and I do want to also provide a trigger warning as I'm sharing my own story. Similar to Ushma, Elizabeth, as well as Barb, I went through my own journey with Crohn's disease. I was a healthy child and teenager. At 22, I was working in finance on Wall Street, and I wasn't quite symptomatic yet, but I had grown up with irritable bowel syndromes and a bunch of extraintestinal manifestations, joint pain, eye issues, as a child and teenager. I was diagnosed at 22 with ulcerative colitis, and this was as a result of pushing really hard to get a colonoscopy. Why did I push so hard? My father passed from Crohn's turned colorectal cancer when he was 39. My aunt in India passed from Crohn's turned colorectal cancer at the age of 43. So I was acutely aware of the fact that this could be running in my family, and it was diagnosed upon colonoscopy. I wasn't given medications at the time. I don't think I was taken seriously. My course became, it was very mild to start, but it became very severe very quickly. Ulcerative colitis is a form of inflammatory bowel disease, as is Crohn's disease. Ulcerative colitis is mainly in the colon and rectum, where it forms ulcerations and you can bleed in your stool. And Crohn's disease really runs from the mouth to the anus and can cause ulcerations and bleeding, as well as something called, this is a very severe complication of the disease, something called a fistula. Fistula can happen from Crohn's disease, it can happen from childbirth, it can happen from a variety of diseases, and it can happen to men, women, LGBTQ population as well. What I went through was, after having multiple surgeries for this disease, I was finally told that this is actually Crohn's disease. This isn't just in the colon and rectum, because my colon had been removed at that point. So I had developed disease in the small intestine. What the disease started to do is fistulize, and it fistulized into my lady parts and into the anus. It was called perianal fistulizing Crohn's and also rectovaginal fistulae. This was very, very difficult. Going back to what Elizabeth has been talking about, I was leaking blood, stool, mucus. I was in septic shock, and I had 6 of them over the course of the ages of 28 to 32. I had recently gotten married. I'd gotten several opinions across the country, and I was told that there were really no good medication options. I've had nearly 24 surgeries for my Crohn's disease. I live with an ostomy bag, and I faced significant cultural stigma, and I do want to highlight this today too from a cultural perspective as well. To get the ostomy bag, to deal with fistula, to deal with an inflammatory bowel disease was so incredibly challenging. We cannot talk about it. It brings shame upon my family. It was questioned whether or not I could get married, let alone my sister could get married. It affects your ability to get married. And then on top of that, when I needed ostomy surgery, to have a bag placed on my abdomen from which I would defecate, I was told that I wouldn't be accepted in my community. My in-laws told me that they weren't sure if my boyfriend at the time should be marrying me. And it was a very, 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 very harrowing journey. I was told that I wouldn't be able to pray or cook because this was considered foul and disgusting. And it was a really challenging time in my life. But in order to deal with these fistulae really is the plural form, I had to get this ostomy. There were no good medication options. I was not responding to medication. And the 3 different opinions I got, I kept asking, there was one drug option left, and it was methotrexate, which is a teratogenic drug. And I was 28 years old. I just wanted to feel well. I was physically disabled from this disease, and I just wanted to feel well. And I was refused, and I know we've talked about this a couple of times since yesterday, I was refused a teratogenic medication simply because I should have the right to choose pregnancy. I was not even capable of pregnancy at the time. So it was, and also with fistula, that the burden can be magnified. The burden of inflammatory bowel disease, it can progress if you do get pregnant. For some patients, not all patients. So for me, it was a very, very mind-numbing situation to be refused a medication when I had no other options and when my disease was completely consuming my life. I did fortunately eventually get into a clinical trial through a PI at a major institution, and that drug has kept me in remission for the last 9 years, but it took so much advocacy, self-advocacy, advocacy from my family to get to that point and to be here today. With that, I sort of wanted to, talk about some of these different aspects of our health, in terms of, we've been talking about maternal health. We've been talking about infertility. We've been talking about chronic illness. And I also want to highlight that women's health is inclusive of LGBTQ health. These are all topics we're going to be delving into a bit today, and I want to sort of continue with this panel and hear more of your perspectives. Barb, just turning to you, how does infertility intersect with chronic illness? What has been your experience? What have you seen working at Resolve? Would love to hear your thoughts on that.
Well, I would almost expand that to just family building, because we heard this yesterday from some of the speakers, you've heard this from a couple of the panelists, where your reproductive system is impacted by other surgeries, other conditions, chronic conditions, medications. Are you somebody who should be talked to about fertility preservation? Are you going to be impacting your future fertility by taking this medication, by having this surgery? We hear this all the time. There are clinical guidelines actually around this, yet they're not oncologists. I don't want to pick on oncologists, but they're not actually telling their patients about things like fertility preservation, because they're like, well, they don't have insurance for it, and I want to get them in treatment. And this is incredibly important health information. Not only that, what if the patient is saying, I'm advocating for the treatment, don't worry about my future fertility, what do I need to sign, how do I need to talk to you about that? So there is this notion that we know better, that the man or the woman facing that potentially threatening fertility treatment doesn't really know enough, cannot handle it, and also doesn't have a health insurance plan that covers it, so we just better not even present it as an option. So we see that. We also see conditions like uterine fibroids, endometriosis, PCOS, major causes of infertility, and they are lifelong chronic conditions. And what oftentimes happens is women don't even know they have these conditions until they are trying to conceive, and then they go, why isn't this working? And the doctor goes, actually, you've had something since you were a teenager. Or, by the way, has anybody asked you if you have heavy periods or if you don't have a period? Or maybe, gosh, you missed work or school because of your menstrual cycle. And every woman goes, yeah, but everyone told me that was normal. So we are missing so many things. I'm fired up, as you can tell, because we have had in this country since February infertility and IVF under attack. I'm wearing my orange awareness pants. I got to light up the Empire State Building orange 2 weeks ago. And I am just really fired up because I'm hearing over and over and over from women and men around the country, like, what have we come to? What is happening? We don't even have a right to choose to when we want to build our family, and then we don't even have coverage for it. And look, we're at a point in our country, I hate to get off track, where people are making moral and religious decisions about medical care and the standard of care that's been practiced for years. Can you imagine if your condition, the most effective treatment for your condition, or maybe what you're providing, all of a sudden a state legislator says, I know better, and we're not gonna legislate that and how that care is delivered. And you're gonna be like, where's the science? Where's the research? Where's the clinical guidelines? Gone. This is happening right now as it relates to our field in Congress and in state governments. So there are so many things that fire up our community, but we are being dismissed on all levels, and then we can't even get the care that we should be getting because somebody has decided that it's morally offensive to them. So it's a whole host of issues that we need to solve. Infertility is women and men, so I don't want to leave out the fact that a third of all infertility is due to male factor. It's not a women's disease, but most of the medical procedures are done on the female.
And I just add to that it's definitely not about science, because as you can hear from your story, my story, nobody trusts women.
Yeah.
Nobody trusts women about it doesn't matter if you are having trouble getting pregnant, if you're having trouble with a pregnancy, or if you don't want to get pregnant. No one listened to any of us.
Yep.
No, and that's, I think, been, the overarching experience is we need to be heard.
Right.
So, and we're gonna definitely get into that a little bit more. What can we do to sort of work towards better inclusion and listening to patients? We're definitely gonna get to that. But I also wanted to sort of get your perspectives, Elizabeth, on the LGBTQ population. What are the unmet needs? What does gender-inclusive patient engagement mean to you, mean to industry? And what can providers and researchers do better?
Yeah, when we started talking about this panel, as a cisgendered white woman who has access to great healthcare, and I am an incredibly privileged person, you still hear that I'm not listened to. And so I think about people of color, folks from the LGBTQ community, people with limited resources. I'm originally from Kentucky, and that's sort of where my passion for social justice came from, because I hear from incredibly impoverished people who are dying from cancer at much higher rates, and things like, my biggest pet peeve is when someone says, but they didn't even smoke. I don't care if they smoked, right? Nobody deserves to, it drives me absolutely nuts, right? And so I come from a family of smokers. The reason I bring it up is because people having differing experiences in the healthcare system, and from an LGBTQ perspective, we've seen a shift in oncology. What if you're a trans man? And talking to your doctor about, first of all, are you going to go to an OBGYN, or what type of oncologist are you going to see? What if you need cervical cancer screening, but you're a trans man? I mean, you've brought up several times sort of the traumatic experience. We need to have incredibly culturally competent, there's no such thing as competence, but culturally humble care for folks who identify as a gender different from their birth sex. We know that the LGBTQ population, and I know I'm preaching to the choir, has worse health outcomes from a cancer perspective. They're less likely to get cancer screenings. And so what can we do? Having that gender and sexual orientation and sort of this SOGI approach to affirming care is incredibly important. If you don't feel comfortable talking about your sexual practices with your physician, you're not going to have those conversations. Then you may not get the screening that you need. And it's just every time I go to the doctor and I emerge confused or feeling like I wasn't listened to, I think about populations who this is their day-to-day. And if you don't feel heard and if you feel discriminated against, you're not going to go back to the doctor. You're not going to get the cancer screening. You're not going to get the kind of care that you deserve. And so when we talk about women's healthcare, I want to be just really clear that it's not just cisgendered heterosexual women. It encompasses anybody who identifies as a woman. If we are talking about trans women, right? What kind of care do they need? So I just think it's really important to put a fine point on. Women don't necessarily need to look a certain way or act a certain way, but we need to be really inclusive and open to all types of women. And so thank you for bringing that into the conversation. I appreciate it.
Absolutely. And you bring up some good points, both of you, Elizabeth and Barb. I think about culturally safe and culturally sensitive and appropriate care, and having those conversations around sexual practices and fertility, you know, about heavy menstrual cycles, all these things with your doctors. But I also want to question, you know, why is the burden always on the patient to bring these things up? Right. Shouldn't this be a conversation that our healthcare providers should bring up? This was often my challenge too. Like, such a stigmatized subject, these fistulas are burrowing holes everywhere, and how am I supposed to bring this up?
Yeah.
What is going on with my body? It's violating me. My body's violating me. It's not even giving me the right to choose, and yet my right to choose is being taken away by the healthcare system too. So you're bringing up some excellent points. Ushma, I sort of want to hear from you now in terms of maternal health, since we've heard some of these other perspectives. What can be done in terms of maternal health at either an individual or systemic level to better empower mothers? And I know you talked a little bit about how it was better the second time around because you were an empowered patient, so to speak. So can you tell us a little bit more about that?
Sure, absolutely. So I think a couple things. On the patient side, I think we need increased awareness and education around pregnancy and all the complications that can happen. And I think that we need to empower women to speak up and trust their gut. You know when something is wrong. And I think this starts early on. So yesterday's sessions really hit home for me. You know, with having a daughter myself, I want to teach her and teach my son on how to be an advocate better, how to navigate the healthcare system. And I think that needs to start at an early age. And from the provider and researcher side, I think we need to train them. We need to train them on how to engage with patients. I think there are a lot of tools out there about how patients and women can do a better job of speaking up. But again, we need to all work together. We're not in this alone. And so the other thing that I want to mention is underrepresented populations. There's a lot of researchers say, well, they're hard to reach. How do we get these hard to reach populations? It's not that they're hard to find. We need to go into the communities and build relationships and build that trust with them to hear their voices, and their voices need to be heard.
Such incredible points, and I think you make some very, very valid points about sort of training our children, training posterity for self-advocacy.
Yep.
You know, what if there was, you know, a class on health in high school, like you and I were talking about yesterday? Yeah. What if some of these life skills were already included in some of our curriculum, so to speak?
Exactly. And then, sorry, one other thing on a system level, I mean, paid maternity leave. Why are we still behind on that? Why do I have to live in a certain state to get paid leave after I have a baby?
Excellent points.
I'm just going to leave that there.
Excellent points.
We don't have to get into that. But, yeah.
So to switch gears a little bit and understand more about what can be done in the community, I want to switch to patient engagement a little bit and understand from your perspective. So we know patient engagement has evolved, especially over the last 25, 30 years or so. And patients are being more involved in terms of shared decision making, or supposed to be more involved. And also patient advocates and lay patients are being more involved on advisory councils and such. So I kind of want to understand what has been done well in the space and what may need a little bit more improvement. So perhaps we can start with Barb.
Oh boy, I don't know.
Loaded question.
I told you I'm a little far. You know, in our space, it's a little bit, we're a little bit different in that reproductive health has not had really all that many advances. I don't know if any of you know this, but NIH is prohibited from doing any research on human embryos. And so we know more about a mouse embryo than we know about a human embryo. Let me just say that again. We know more about a mouse embryo than a human embryo. So we're way, way, way behind. And the private sector has not filled in that gap to the extent that like an NIH would. So we don't see a whole lot of research for women and men in the infertility space. It might be something specific to endometriosis or specific to uterine fibroids, but overall we don't see a lot of that. What we have seen is our partners, our pharma partners and others have supported Resolve in our advocacy work. And that has really been incredible because I was telling Eric yesterday when I saw him that we have over 1,000 people registered for our Federal Advocacy Day. It's virtual, so it's very accessible, and it's next Tuesday. So that's 1,000 people. And so we've been able to provide that platform where they can talk to their members of Congress and so forth, and we train them. And we train them how to tell their story and how to advocate. That might be done at their employer, that might be done at state capitals, that might be done with the federal government, but patient advocates, that's our role, is to inspire people to act. And that I take that very, very seriously. And if we don't have all of our partners coming together to help us do that, we're nowhere. So that's really an area where I've seen in our community. I was on a call yesterday with our Virginia state delegation for Advocacy Day, and a woman goes, yeah, I haven't been involved with Advocacy Day for about 7 years because I participated when I was building my family, when I was struggling. And now I have kids, and it's been hard, but she said, I can't let my kids go through this and what I've gone through, so I'm going to be showing up every year. I'm coming back. So that's the empowerment and the advocacy that we see is it's this, I'm sorry, the status quo is not acceptable. And shame on me if this is still the status quo for my kids.
Great point about self-advocacy and empowerment. How about you, Elizabeth? What are your thoughts on this?
Yeah, I've been at Sanofi for 2 years and some change, and before that, all nonprofit patient advocacy, social work, and navigation. And so when I started at Sanofi, I would say either they're going to love me or they're going to fire me, and TBD, but I still have a job. The reason that I bring it up is because my boss, Eric, who is very involved with NHC, is fantastic. We'll have conversations around sort of the best ways to work with patient advocacy organizations, and I can just straight up say, that's a terrible idea, and he's like, got it, off the table, right? Like, and not that he has many, he's my boss, he's fantastic. But he says, like, is this something that we should be doing, and is this a way to partner and really listening? We have something called the Patient Charter, which Randy and the team were fantastic about looking at it, providing feedback, and it's up on our website, and we talk about the things that we're gonna measure and the things that we're going to report publicly. So, not just we're going to invest in diversity in clinical trials. Okay, what does that look like? What does that mean? How many people of color on your clinical trials? How we work with patient advocacy organizations, really putting our money where our mouth is. And I push back all the time in terms of, I think every company says they're patient-centric. Okay, what does that look like? What does that really look like? And how are you engaging patients and report on it? And if we're not doing a good enough job, then I feel like I can say we're not doing a good enough job. I was having, early on in my tenure at Sanofi, I got to have dinner with our CEO, and he's sitting next to me. And I said, I have really enjoyed the transition from nonprofit to corporate, and I feel like this is a very patient-centered company, but the day that I don't is the day that I quit. And he said to me, before you quit, please call me, because if you feel that way, then we're not doing our job, and I shouldn't be here either, right? And so it's not just a platitude, it's not just a cliche. I really do think that, like, reporting on how you're going to engage patients, we take the feedback from our patient advocacy groups really seriously. It's not just a survey about, do you like working with us? But what are we doing right? What are we doing wrong? How can we get better? So, and it's critically important to do this stuff.
I love that. Thank you so much for sharing that. I think we all need to hear that from time to time, how invested industry can be too in patient engagement and wanting to make sure that the patient voice is heard. So thank you. And how about you, Ushma?
Sure. So I think in terms of what has been done well, I think there's certainly a shift from person-focused engagement where patients are empowered, they need to be actively involved and do shared decision-making with their provider. And there's a shift to a more system-level organizational involvement of patients. So you have PFACs, you have advisory boards, patients are getting involved in research, and there's also organizations like PCORI who are funding research on women's health and on maternal health, and they're documenting what it really truly means to have meaningful engagement and what that looks like. In addition, I think we're seeing more opportunities like this, conferences that are bringing together patients, patient advocates, funders, payers, policymakers. That's not certainly something that I saw about 10 years ago. So I think we are making some strides.
Thank you for sharing. I think as a patient advocate for myself, something that I've seen done well is some of the things that Elizabeth has been sharing. But one of the things I wanted to highlight today was also with clinical trial engagement, patient engagement specifically, and I was talking to a few folks about this last night too. I've often been brought in to look at endpoints and what's not working when a trial is failing, when that drug is going to be taken off from that disease area, even though it might work. And what I've often gone back to industry and said is, look, you need to have us involved, us patients involved from the very beginning when you're planning these trials. That's patient centricity. And I think that's a point I do want to drive home tonight about something we can do better, especially for women who have generally not been included historically in some of these trials, and women of color and LGBTQ population. Include us from the beginning. We have thoughts, we have ideas about what might be a good endpoint, when might be a good time to sort of move into open label, various details. Patients do have the knowledge, we can be trusted with this information, and we will provide the right guidance. So that is something that I wanted to share today. Now, just in kind of closing up this panel, I wanted to ask one last question, and perhaps we keep this a little bit quick so that we can get to our Q&A section. Just as a final call to action, what would your recommendations be for next steps for the future of women's health and research and engagement? Why don't we start with Barb?
Find ways to let women's voices be heard, and whether that's investing in patient advocacy, whether that is finding ways to train and listen to patients, or whether that's working on the clinical side. Just remember that as you walk away from this today that women don't feel heard. And that is, I hope, the message you hear. And however you think you can take that and make strides, please do.
Yeah, I think women not feeling heard will be the moral of this panel for sure. Tina, I completely agree with you. I think you made a really good point around the onus should not be on patients to be the ones to make change in the system. But I do want to bring up, and when we talked about this on our prep call, I really don't like the word advocacy. I think that it's weak, and again, this is probably why they'll fire me one day, but let's go back to activism, right? There's a reason why in the AIDS crisis that activism was the word of choice, because no one was listening to them, and there was no sort of pathway, no rule book that they were following. And so, that's why things moved so quickly, and that's why work got done because of activism. So I think when it comes to people not being heard, approaching it from more of an activist perspective and saying this just simply isn't good enough. We should not be having to suffer. We should not be having the fact that I would love one day to not have this panel at all, right? We shouldn't need to have this panel, and hopefully that's how we'll get there.
Completely agree.
I love that point that you bring up about patient advocates, because patient advocates are not always equal to unaffiliated patients. So how can we get people that may not be part of an organization or have the resources to participate in these opportunities? I think it also starts with leadership buy-in and commitment. So I'll share just a very short story. I shared my story many, many years ago, and I had pictures during my slideshow. And after the talk, nurses came up to me. I never stated what hospital that this happened at, but they recognized the room from the slideshow. And they asked, we want to partner with you. Will you help us build a PFAC? And of course, I said, yes, sure. Here's my information. I tried to reach out multiple times, and I never heard back. It took so many years. So 7 years later, they came to me and said, all right, we're ready. And so obviously the nurses wanted to partner and work with me, but there must have been something going on an organizational level or system level where maybe they weren't able to really commit to building a PFAC. So I think it starts at top as well. And then finally, I think it's not just a woman problem. I love that this session is focused on women, but again, this is a human issue. Everyone knows a mother, your daughters, sisters, friends, colleagues, neighbors. And so I think we really need to work together to fix this broken system. And a couple weeks ago, I even saw this term called kintsugi, which is a Japanese art where you take a broken pottery piece, and you're using gold glue to put it back together. So how can we, this is the call to action to all of us, really, how can we be the gold glue to put together the broken pieces?
And just thank you for sharing that. And just as a piece of show and tell, I just wanted to share a kintsugi bowl. I was involved a few years ago with a nonprofit called Girls with Guts. And what we had done at a patient retreat was taken bowls, much larger bowls, taken a hammer to them, and then put them back together with gold glue. So why do we bring this up today? Kintsugi is the art, the Japanese art of putting broken pieces back together. We've all talked about the different ways that the healthcare system may need some mending, some fixing. Many of us have put ourselves back together as patients to be here today and to speak and to share our traumas. I think we can take that and work together as patients, as healthcare professionals, as nonprofit organizations, and as industry to really put these broken pieces back together with gold glue and make this even more beautiful than ever before. Women's health is important. We deserve to be heard. Marginalized communities, including the LGBTQ population and including people of color, need to be heard, and we need to start with it today beyond having panels like this. We need to take that lip service and put it into action. Thank you, everyone, for joining us.